older than they have to go.
It was great. It was great for like 8 years.
Yeah.
And then it's just started. I'm like, I mean, you can only do so much. I can't complain. Good morning, Craig.
For your holidays.
I muted it.
that work? Good morning. Can you hear us okay?
Got a thumbs up from Misty, so.
And Gladys said yes.
Okay.
Some people.
Yes.
Okay, thank you. So let me start over with a roll call. We'll do this one more time. If you are in the room, please indicate that you are in the room. If you're in the virtual room, please indicate if you are joining by phone and or video. So starting over with a roll call, Craig Anderson.
Here in the room.
Thank you. Gladys Boutwell.
Via Teams.
Thank you, Gladys. Ron Gallinat.
Yes, virtual.
Thank you, Ron. Paul Harmon.
Here, phone and video.
Thank you. Lindsay Hopper.
Morning in the room.
Ines Kemper.
You were
Ines-
muted.
Inez Kemper by video.
Thank you, Ines. Joni Moore.
Present by video.
Lindsay Shirahama. Holly Sorensen.
Good morning. I'm here virtually over Teams.
Thank you, Holly. Andrew Stolfi is not with us today, but TK Keen. By proxy. In the room by proxy. Fantastic. Thank you. Om Sukinai.
Oh, virtual. Good morning.
Good morning. Drew Tarab.
Good morning on virtual.
Thank you, Drew. Nashoba Temperley.
Going to be able to.
Okay, thank you, Don. Thank you, Don. Mary Beth Guarino.
Here by Teams.
Kathleen Johnson. Fantastic. So 12 out of our 15 members are here today. Craig, back to you.
I think I missed it. This is Lindsay Shirahama. I am present. Just
Fantastic.
jumped in a little late.
Thank you, Lindsay, and welcome.
Thank you.
Going to the next slide.
So I think, Craig, we need minutes, please.
Okay, thank you. Okay, so next is we're going to approve the minutes, and those were sent out originally by Dawn on January 4th and then sent out again with the updated packet. So hopefully everybody's had a chance to review the minutes, and is there any discussion?
I'll move approval of the minutes. It's Ron Gallinat.
All right, thank you, Ron. Do I have a second?
I'll second. This is Holly.
Thank you, Holly. So all in favor, I think if you could do a virtual hand up.
Yes.
Okay, that's how we'll do that. And in the room, we'll just say aye.
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 That we passed.
Good, okay. Right. With
Go
that,
back to the meeting protocols.
yeah, we should do the meeting protocol. Thank you. All right, just as a reminder to everybody, the marketplace is committed to having safe and inclusive meetings for all attendees. Please offer your opinions. There are no bad questions or silly ideas, so we do want everybody to participate. And as always, if you do see unacceptable behavior, please let Chicky know that. And also as a reminder, please be on camera as much as you can. If you have questions, please raise your hand and we'll make sure we get to you. And there are options to turn on captions if you need that. Okay. All right, so our first agenda item this morning, we have Stephanie Keenan back with us to give us a federal policy update. So I saw Stephanie out there, so I'll turn that over to you. Thanks.
Hi, good morning to you all. In some ways, January is a quiet month in Washington, D.C., and in some ways it can be a crazy month. The last time we spoke was the last Congress. They came back, passed legislation, and went home, and now we are in a new Congress. Just to give you kind of a broad perspective of some of the issues that will be taken up in healthcare. At the HELP Committee in the Senate, which will be headed up by Bernie Sanders, he has made a very big deal already that he wants to look at prescription drug costs. And in fact, he has brought on someone from who has not been a Hill staffer before, but has a lot of experience in prescription drugs to focus solely on that issue. I will also say that some of the things he talks about are not in his committee's jurisdiction, but we'll see what he ends up doing. The equivalent committee in the House is the House Energy and Commerce Committee, and that is headed up by Congresswoman Catherine McMorris Rogers, known as CMR now because her name is too long to say. CMR has already issued press releases slamming the administration about extending the public health emergency on COVID. And she's already said that she wants to spend some time looking at where the money went on the COVID, for COVID in general. And other than that, she has not announced any particular agenda for that committee yet. And that committee has a very broad perspective. Not only do they do healthcare, but they do energy issues, consumer issues, and some telecommunications issues like broadband and that kind of stuff. The Finance Committee will still be headed up by Ron Wyden, and the equivalent committee in the House sort of is Ways and Means. When they worked out the chairmanships, it was supposed to be Vern Buchanan from Florida by seniority. Mr. Buchanan did not get the chairmanship, and it instead went to a much junior member named Jason Smith from Missouri, who's very conservative, a member of the Freedom Caucus, and he's 42 years old, so he could be chairman for a very long time. He has also been a health player in Republican circles. He's very substantive, just very conservative. One player that I want to mention in the Senate is Senator Cassidy from Louisiana, who's actually a physician. He will be the ranking member on the HELP Committee, and he's also on the Finance Committee. As a member without a ranking position, he had 3 healthcare staffers in his personal office. That's how important healthcare is to him. He has brought on a number of really substantive, serious folks to staff him at the HELP Committee in his ranking position. And he is someone who likes to cut deals. So it's very likely that in some ways, Senator Cassidy will be a more significant player than the chairman, because Cassidy will want to cut a deal when Sanders doesn't. So a lot to look for in those committees. I want to talk a little bit about the House and the way they have structured and what to expect. You all saw the 15 ballots for McCarthy and a speakership. It's sort of the backstory of what rules they actually adopted and the Rules Committee, and why should you care about something called the Rules Committee? In the House, the Rules Committee literally scripts every piece of legislation that goes to the floor. They decide how long the debate will be. They decide what amendments will be in order. They, in fact, they haven't done it in recent memory, but they can marry up bills and package bills together. They can make some tweaks in the committee and send it on. If it doesn't get through Rules Committee, it doesn't go to the floor. Speaker McCarthy has put 3 very conservative members on the Rules Committee who don't like to spend money. And for people who advocate for programs like Medicaid and Medicare and a variety of programs where you're spending money, this is sort of a red flag of these folks aren't going to let a lot of bills go to the floor if they spend a lot of money. So that's something to keep in mind as you watch what happens in DC. The other important change is that the House and the Senate used to operate by something called pay-go, meaning that if your proposal spent money, you had to pay for it. Didn't really matter how you paid for it. There were some parameters, but you had to pay for it. The House has now adopted something called cut-go, not pay-go, but cut-go, which means if a bill increases spending in the budget over 5 or 10 years, depending on how it's costed out, then there has to be a reduction in a mandatory spending program. Mandatory spending programs are Medicare, Medicaid, and Social Security. So that's another red flag of it's going to be hard to get anything really done in healthcare that spends money. The other thing I wanted to just touch upon briefly is the debt limit issue. Today we hit the debt limit. Everybody's screaming and ranting and raving, rightfully so. The House wants to negotiate the debt limit. What is it? When we hit the debt limit, it means the government can't borrow money anymore. And they're essentially operating the government on cash on hand. And at some point, probably in June or July, the receipts coming in will be not enough to pay for what we need to put out. And the government would then default. And the House wants to use this as leverage to substantially reduce spending in the budget. And even within Republicans, they're split. Some want to prioritize payments. For example, they would prioritize bondholders first, and then they would prioritize other programs. Then there's a group of Republicans who think prioritization is too controversial and just not where they want to go, and they just want to negotiate how we spend or don't spend money in entitlements and in other areas. And over in the Senate, Senator Romney and Senator Manchin, a bipartisan duo, have dropped in a bill to create what is known as a rescue committee. And that committee would have jurisdiction over looking Medicare, Social Security, and even highway trust funds. They haven't mentioned Medicaid yet, but it's lurking in the background. Essentially trying to make Medicare, Social Security, and any other trust fund solvent, but they could also look at other spending like Medicaid. So I think in the next few months, that's going to take all of the oxygen out of the air until they figure out what to do, and there won't be a lot of progress on other issues. Having said that, in February, the appropriations process starts with holding hearings and finding out what programs people want to do, spend more money on, and what changes they want. The House is also going to look at every program that has not been reauthorized but received money in the appropriations process. And let me give you an example. Several years ago, the authorization for the Older Americans Act expired, and Congress didn't do anything for 5 years. But those programs were continued to be funded because the appropriators assumed that at some point, the Older Americans Act would be reauthorized. It meant nothing could change, but in the way the program operated, but it meant that the programs continued. The House Republicans want to look and see, they haven't said what they're going to do yet, but they want to look and see what has been funded but not reauthorized. So there's a lot of nervousness there too, because there are a fair amount of programs that haven't been reauthorized for a variety of reasons. So we're looking, February is going to be a very busy month in terms of a lot of hearings, a lot of people bringing up issues. Mental health is still a very big issue, mental health / opioid abuse. I know that the Senate Finance Committee is working on legislation related to organ transplants. There's going to be a lot of stuff flowing around. This is going to be a very condensed period of time in which Congress can really get anything done, in large part because of the presidential race, and when that will start next year. So everybody who wants to get something done views this year as the year to get it done. So there will be a lot of activity, a lot of things flying around, and a lot to track. But I suspect that Medicaid itself will not be the issue. It'll be the programs that Medicaid works to help, and additional programs like mental health and substance abuse are going to be out there, sometimes on the chopping block and sometimes not. So it's going to be a crazy, probably much more crazier year than we've had in a long time. With that, I'd be happy to take any questions.
Are there any questions for Stephanie? Looks like Gladys has her hand up. Go ahead, Gladys.
So one of the things that you mentioned towards the end was transplants, and I have a lot of clients. I'm an insurance broker, and so I work with a lot of dialysis patients that are getting transplants at OHSU. So do we know what kinds of changes they're trying to make? Are they trying to limit the type of transplants, or who gets transplants? Do we have any idea on that?
Finance Committee held a hearing last August, basically on the shortcomings of the system. He is looking at tracking organs, the finances of the organ procurement organizations, patient safety issues, and a couple of other issues. It's more looking at the system as opposed to who can get a transplant and who can't get a transplant. There's been a lot of controversy, in particular with kidneys, and I've learned this fact, not that I'm happy to know this fact, but apparently with kidneys are removed without necessarily a match. And so that there are more, because there's such a need for kidneys, so that there are more kidneys out there. And the discard rate, which is not a happy term either, is fairly high right now. And that's another area, is looking at why are the kidneys not being used as, as well as there are so many kidneys being donated, why aren't they being used? But I'll say organ tracking seems to be an issue the Finance Committee has really latched onto, and most organs travel with a team. Kidneys and livers do not. So that's why they're focused on tracking those particular organs.
Thank you.
You're welcome. Glad I know that obscure little area. Anything else? One thing I did neglect to mention is that there is an FDA proposed rule they're hoping to finalize this spring that will help move drugs from prescription to over the counter. And that is another part of the Biden administration's effort to lower prescription drug costs. It could have some significant issues for some people as they move along through the system, but we'll have to see what happens.
Hello, can you hear me?
Yes.
My name is Darrell White. I'm with the Urban League of Portland. This is my first time attending this meeting. And I just want to ask the question. Our agency is going to start looking at our advocacy department that does a lot of work in the legislation and stuff like that. What can be done about adding some type of, or updating, or how it be vision and dental to some of the people who's not eligible, doesn't get it through the Oregon Health Plan? I was just wondering, will we be fighting a possible battle trying to get something with that, or is there something in the works or anything?
Well, that's not necessarily a federal issue. There was an effort to add vision and dental to Medicare, and the dental got dropped. But I think on the Oregon Health Plan, your folks would be better able to answer than I.
All right.
Thank you, Stephanie. Any other questions? Okay, so let's move on to the next agenda item. Okay, next we're going to be led in conversation by Chicky on an open enrollment initial debrief, and she'll talk about the outreach, education, and enrollment. And I think she's going to have some assistance from our community partners and agents as well.
Thank you, Craig. Good morning, everybody. Again, this is Chicky Flowers. I am in the room over at 500 Summer Street. I am the director of the Oregon Health Insurance Marketplace. So as we all know, we have this thing, I kind of say it a little jokingly, we have this small thing called open enrollment that we are busy with every year. It's November 1st through January 15th. And of course, that just ended this past Sunday. So I'm sure Gladys can breathe kind of maybe just a little bit. I know they've been super, super busy. So thank you so much for all your work to all our community partners, agents. They have been hustling like crazy. And I say that with a lot of respect because it is no joke that open enrollment is a very, very busy time every year. So open enrollment just ended. We did receive initial numbers from CMS, and of course that is not allowed to be shared at this time. It is currently embargoed. I can say that at this time, we ended open enrollment a little lower than last year's numbers, and we're hoping that CMS will release those numbers next week rather. But in the meantime, would love to hear from our committee members of how did open enrollment go? So initial feedback that you've heard from your clients, from the community members. So what are you hearing regarding how OE went in general? So here are some guide questions for you in front of you on the screen from consumers, communities, community partners, and agents. And have you heard of any success stories or customer service needs we should work on? So would love to open the floor. And I think I already saw a virtual hand up from Ines and then Gladys. So maybe if we can start with Ines first and then Gladys go second.
Okay, hi there. So I am a consumer and had to use the system to choose my insurance. So just as a background, I'm a cancer patient, and therefore I have an oncologist, and of course I have my primary care physician, and they're not in the same system. One is so when I tried to sign up for insurance, I entered both of their names because they're non-negotiable. And the system gave me like 15 choices, but most of those didn't cover both of my doctors. It turns out that only 3 of the plans actually covered both of my physicians, but it came up with 15, so it was really difficult to cull through and and just find the plans that I could use, the 3 plans. So that was one disappointing experience that I wanted to share. In the process, I also tried to find lifetime maximums, because when I had a PET scan, I was told that insurance carriers only do 3 PET scans in a lifetime. And that information wasn't available anywhere. I couldn't figure out if another insurance company would do multiple PET scans. So frustrating again. And also along those lines, I tried to find prescription maximums, and maybe they're in there, but it wasn't obvious to me. My cancer doesn't have a treatment, and new cancer drugs can be extremely expensive. And I'm expecting in the next few years there probably will be something for me, but it'll probably cost hundreds of thousands of dollars. And I can't tell from the website if those would be covered, or if what the maximum is on that. I understand that research medicines are not covered, but like once they actually go on the market. Those were my observations in the process.
Thank you, Ines. Clarifying question, please. When you say system or website, which one are you referring to, please?
The marketplace sign up.
So healthcare.gov or
healthcare.gov. Yeah.
Okay, thank you. Thank you, Ines. Very fabulous feed. I'm sorry for your troubles. That's definitely not the experience we want, but we are definitely writing down everything that you're saying in the hopes of advocating for a better consumer experience. So thank you, Ines. Gladys?
So what I found as an insurance broker is that I got more calls this year than any other year where they found me online because they had a lot of questions. A consumer did, where they were trying to do their own thing and they're like, you know what, this is a little much, a little over my head. I need help. And they were able to find me based on zip code. And so essentially it was Hubbard and Wilsonville is the consumers that I got this year. Whereas before if I got one, that was, and this year I think I got maybe a half dozen that called me that was found through the Oregon marketplace because they were looking for local help. So that was really nice to see that. The other thing was that the carriers, they are in overwhelm. This was a very heavy, to say the least, open enrollment, more than any other year. I thought it was just me. I was working more hours than I had in any other, and I always work a lot, but this one was a little bit more. It was a little crazy. And as things started to slow down in January, in speaking with other brokers, they were feeling the same thing. And then the carriers were also feeling the same thing. In part with the carriers is they have less staff. So they are understaffed. And because they're understaffed, that means that there's things they can't process as quickly. And so things that might have been done on the group side, because that's where I noticed it, on the individual side also, but with groups, there was things that were uploaded and done at the beginning of November, and by beginning of January, they were just getting to it. A lot of times with the individuals, things are getting auto uploaded, but when it was anything that was just slightly different, that's where there was a delay because somebody had to go in and actually take care of it. It took over 2 weeks for somebody's birthday to get updated into the system of the carrier, even though Marketplace had already sent it. It was just this whole convoluted piece of it. But overall, I think a lot more consumers knew exactly what they wanted to do, and more were seeking out help. And just the postings on Facebook, I got responses on, and then, oh, I found you on Facebook, or other people on Facebook were mentioning your name, and that's why I'm reaching out to you. So that was one thing that the online social media community was truly, this was the first year that I've seen where there was an increase in consumers finding me, or I'm sure other brokers too, but that was at least my experience for this year. And just clients were just happy to have somebody to help them through. So that was a good experience this year, although it was a little crazy and still trying to clean up a little bit of the data match systems because something wasn't matching up.
Thank you very much, Gladys.
Jackie, can I ask a
Yes,
question?
please, go ahead.
Yeah, thanks for that feedback, Gladys. I'm curious about the social media that you mentioned and the greater number of referrals. Did something change this year, or do you think people are just getting more familiar with that?
I think it's a combination of different things. one is that I've built really good relationships with others. And so when one person asks a question like, hey, I'm struggling with finding, my provider, I don't know which carrier, or my premium went up. And so then somebody will say, they'll post, talk to Gladys, she helped me, or she helped my client. And then somebody else will say, talk to Gladys. And then the third one will say, talk to Gladys. And when you start seeing the same name pop up multiple times, they go, others that are watching, not just the one that asked the question, but others said, I saw your name, it was through that. Others were because I posted on social media information, open enrollment videos, and just throwing information out there. So the educational piece was another one. So the social media groups was one. The social media, my postings, which I had more this year than I had before, and also the networking that I did within being in networking, online networking events. And number 3, more consumers actually being savvy enough to say, I'm going to look for help, and then going online to say, okay, where do I find a broker around me that can help me? So I think it was like 3 different pieces that all kind of came together this year, which worked out pretty well. So that was kind of a nice thing. And I wasn't even on the on-demand system on my cell phone. For some reason, I didn't link it properly. Otherwise, I think I probably would have gotten more through the on-demand via my cell phone too.
Thank you, Gladys. Any other questions for Gladys or Ines at this time? Don't worry, we still have plenty of time for questions if you think of them at a little later time. Okay. Ron, I think you're next, and then you're after Ron, please. So Ron?
Thank you. One of the issues this year, it has been for several years, is when people search for healthcare.gov through Google, as an example, they get a number of websites that come up. And it's a real challenge because people will just go to the first one and put in information. Then they get phone calls, emails, they get bombarded with questions or with contact from other people. And of course, it's not the healthcare.gov website. So I'm hoping that when the OHP letters go out, I hope there's a way that when people Google to find out what they can or can't do, that they get to the most appropriate website. That's my first comment. Second one is I came across a couple folks this year who contacted me, and one is a family of 5 who their agent never brought up healthcare.gov. And I don't know if this person doesn't believe in it or just doesn't know about it, but they would have gotten about $600 a month in tax credits over the last couple of years based upon their consistent income, et cetera. And so they were pretty disappointed, but I got them on healthcare.gov and they're good to go. So I just would hope that every agent would be somehow required to let people know about healthcare.gov. It can just save quite a few people quite a bit of money. I came across a prescription drug topic. It was a Medicare person actually on a Part D plan who needed a cancer drug, and there's a generic available for that cancer drug. And through his particular carrier, his Part D carrier, and they all charge differently for these different drugs, but it's about $8,400 a year for that generic drug through his Part D plan. GoodRx has it for about $1,440 a year. And then I looked on Cost Plus Drugs, which is an online pharmacy created by Mark Cuban, who owns, I think it's the Dallas Maverick NBA team. Anyway, the annual cost is about $173. And so I'm letting everybody know about, make sure you look at these options. And when you use GoodRx or Cost Plus Drugs, I don't believe you can run it through your insurance. So, but that's okay. If you can save that kind of money, I'm sure you're happy to pay it direct. That's all I have. Thank you.
If I may add to Ron's comment.
Please go.
One thing that I do, and being in insurance, is that when I am picking up a prescription, and this is for all of you information, look up GoodRx and then ask the pharmacy, how much is it going to cost me with insurance? And then look at how much GoodRx is, whichever one's cheaper. 100% of the time for me, the insurance has been cheaper than GoodRx, but you know what? I'm still checking because you never know. I might have a pricey one that I might go, hey, I'm going to save 10, 20 bucks. I'm going to go with GoodRx and not use my insurance. And that's okay. You know, we're looking at the pocketbook. So thanks for bringing that up. And yes, Cost Plus is amazing. They are adding more drugs every year because they are trying to reduce the amount of the spending. So if it's something that can be ordered online and it's not needed like today, anything that's refrigerated, they can't do. But yes, it is a wonderful tool. And yes, we hope that all the agents are sharing that information with our clients. So thanks, Ron, for bringing that up.
Yeah, the GoodRx is a good option. And by the way, Fred Meyer quit taking GoodRx. They use a different discount company. So thank you.
Thank you. Your suggestions are definitely making my brain kind of roll, especially as we get ready for public health unwinding, public health emergency unwinding strategies and tactics. So thank you. Keep them coming, please. And if you have thoughts at a later time, please always email us. We will find a way to make sure we try to implement your suggestions. So thank you, Ron. Thank you, Gladys. Yes, TK, go ahead.
So I know historically, when the marketplace was at DCBS, we kind of left the messaging exclusively to you all because it was very convenient that it was all in one spot. But as I'm going back and looking at like what we did this year, I think there might be some opportunities for DFR and DCBS to also just kind of push out reminder messages and push people to you all through our networks, because I think maybe in the transition, just some new thought to those communication channels could be helpful.
Yes, please. So we will definitely take that offline and find ways to better synchronize again in our communications. All right. Thank you, TK. So, ready for us?
Yes, sure, for sure. Yeah, good morning, everyone. My name is Sakina. So I'm coming as agent broker. My agency is Chen-Halem Insurance Associates and in Newburgh. And this year has been, as always, busy. But the reason I'm doing this, earlier in 2022, I got opportunity to do a meeting with the marketing company to the agent storefront. And the comments that we got from my colleagues as a broker that most people don't know when the open enrollment is. So I use the strategies and I launched it in with the Medicare. So first, on the personnel side in September, the kind of last 2 weeks of September, we begin our mental and physical. And then we launch out that, hey, Medicare and open enrollment together. We send it out to social media, kind of like gadgets, postcard. And what we did is we make an appointment via Zoom, which is very effective. And I do have people come in person too. So on the enrollment side for this, it has been very good for me. Within, I think, less than 2 weeks, I enrolled more than 100 members and I got the award from CMS. And that's just because we let people know this is open enrollment. Based on history, people already want health insurance, but they don't know who they want to go to. And, by having social media name recognition in the community. And also this year, just like Gladys, I got a lot of phone calls that people search for help. So that would be one thing. In terms of choosing plan, which I think is very important, every sessions for our clients that we meet, we will have at least 45 minutes because I'm dealing in the group of people who English is a second language. But even though they speak only English, we always ask more about what you need. Learning from the experience when we have the easy pricings like standard bronze, I get very concerned about that because I do ask first, on the income, hey, how did you pay tax that you have to pay back? And everything said, no, everything fine, good. And then how much you pay out of pocket for your cost. And then people would say, I have so-and-so, I have to go draw blast every 3 months. So this year in 2023, they're more shifting from bronze plan or standard bronze to silver plan, and also the doctor search and some other questions we asked about them. In terms of drug, I learned more on the Medicare that just like Ron said, the cost plus drug has been efficient. But even so, when we choose a plan for our clients, we want to make sure, hey, just one day, if Mark Cuban sold his company, the insurance company should pay for your drugs. So, yep, it has been very good. So far, so good. Any questions?
Doesn't look like it. Thank you so much, Appreciate the feedback very much. Holly?
Thank you. I just had a follow-up question for Gladys. You had talked about doing some work on cleanup on some just data mismatch type situations, and you mentioned date of birth and things like that. Are you seeing any instances where the information about tax credit amounts and out-of-pocket premium payments change as they're communicated from the marketplace to any carriers? Is that anything that I'm just kind of curious, because that's something we've been seeing with one particular carrier?
Yeah, not that I've heard or seen. I had somebody that had given me the initial information, and as I'm kind of like, it's asking those questions. And Ron, we're asking the questions as we get the initial, we tell them this is what it is, and they say, okay, well, for this particular person that I have in mind right now, her deductible and max out of pocket was at the lowest assistance. They were at a -4, which was that slight reduction, but not a whole lot. And then as I'm inputting her information, then I'm like, okay, is there, and I emphasize, is there anybody else that you put on your taxes? It's like, oh yeah, well, my husband has the kids that he claims as dependents, but they don't live with us, but he's claiming them. It's like, okay, but they're on your taxes and they will be. I mean, I emphasize and make sure, because like and Ron had stated, it's like, oh, did you pay? Because of some of these data mismatches could cause that. And then it's like, well, yeah. And it's like, okay. And that reduced their deductible and their max out of pocket, because instead of a family of 3, it's a family of 5 still earning the same 50 or 60,000, whatever it was. So then it brought her down to like a $750 deductible with a 2,000 max out of pocket. That made a huge difference, because she has a lot of medical issues. She's I think she's on dialysis also. So that was a huge difference. I have not heard back from anybody saying, hey, my max out of pocket is more than what it was originally stated to them. If there is a change, it's sometimes because of that income difference that once we update it in the middle of the year could potentially change it. But overall, I haven't heard that just yet. I don't know if or Ron have encountered that that issue at all. No, Ron says no.
Well, there is one, Holly, that just happened to me. I have one coming in, and I help her on Friday the 13th. So she's put in an income, and then on the 16th, she came back and she said, hey, you know, the income I gave it to you is incorrect. So we tried to update the applications. Somehow the marketplace, this is healthcare.gov, did, you know, send it out taking the income that is higher and, you know, showing that the subsidy is lower. Somehow it came back that they enroll her at the original plan or original subsidy on Friday the 13th. We corrected it like 3 or 4 times. It's still not happening. But in terms of mismatch, when they get the cost sharing, you know, one thing that we always do that I always, because we use a broker platform, is called Help Sherpa. I always making sure that I look into the summary of benefit that generated by CMS, that, you know, I see the max out of pocket is there. And, you know, if we meet via Zoom, I send that as an evidence. Hey, this is your, go tell your doctor. That's it. That's it, your benefit. It's not for me, it's from the marketplace.
Right.
Do I answer your questions?
Yeah, I do the same thing. I always email them the information. It's like, here you go. And whatever they're getting from the carrier should match what I'm emailing them, saying this is your summary of benefits. And that way they can do that comparison. Right on the same page.
So Holly, I know Katie and I already messaged each other. She will be following up with you on your finding, and we definitely would love to follow, you know, kind of figure out next steps for that. Fantastic information. The team and I, we are furiously writing down notes left and right. I know we are reaching close to the time for this agenda item. However, I don't want to stop anybody if they still have other content, other details they want to share. I don't see any other hands up, but if there's anybody else who wanted to share their feedback. Okay, so if I can just offer maybe Miranda and Michael to take a quick maybe 30 seconds to a minute of what they're hearing from other community partners and agents. So Miranda Amstutz is our community partner liaison, and Michael Wallace is our agent liaison. If you can just share other feedback you've heard from our other partners, that would be fantastic. So let's start with Miranda, please.
Hi, my name is Miranda Amstutz. Thank you for the introduction, Chicky. And I actually, Holly was prepared to share some of her experience as a community partner during open enrollment. So I'm actually going to let her have an opportunity to talk. We were just a little confused whether that was where she was supposed to share or not. So now that we know, I'm just going to let her give her update she was prepared to give. But first, before that, actually, Holly, I have an update from Neshoba also, who was unable to join today. Neshoba wanted to share a couple of things he noticed during open enrollment. And that was one of the communities that we have a focus, which is the LGBTQ community. He noticed this year, and increasingly each year, that individuals from that community are, they have more and more of a higher health literacy. So as they're coming to Cascade AIDS Project for assistance, their need and demand for assistance is changing. So what's happening is they're coming and needing more help finding which plan is best for them, rather than needing help with like the full-on application process. So he has found that really interesting. I wanted to share that. Also, when we had our community partner check-in last week, all of our community partner grantees shared with us that they are finding more and more immigrants coming and needing assistance. And so that is something new that they haven't experienced before. And then there was also, they were really surprised that there were a lot less people impacted by the family glitch than they expected. So that was the feedback that we got from our community partner check-in last week. And then I also wanted to allow Holly the opportunity to share her experience as a community partner.
Thanks so much. Yeah, I looked to my small team for their feedback, since they are currently both doing a lot more enrollment assistance than I personally am. And so many of these trends that I have are kind of coming from our assister that's based in Wallowa County, which is a very remote rural frontier, northeasternmost tip of the state. Most of our trends were positive, but like I had mentioned in my question to Gladys a moment ago, we had that concerning trend where we've observed something's happening with the information being communicated from the marketplace to the Moda Health carrier, where something happens to the premium and the tax credit amounts, where the billing ends up being inaccurate. And so that's caused a lot of confusion for consumers. And so kind of like what Gladys and Ohm are working on doing, we're just supporting consumers on a case-by-case basis to mitigate that and ensure that they're paying the right amounts according to the marketplace. Other than that, we also noticed in Wallowa County, not many consumers enrolled in dental plans this year, but they prefer to utilize the federally qualified health center that's providing dental on a sliding scale fee. And so they just take advantage of that being available instead. Also, in Eastern Oregon, we now have 37 different plans to choose from, where 2 years ago we only had 6. And while we have many more options to choose from, it seems like there are some higher contenders. It seems like Moda plans for affordability and benefits. And then Pacific Source is really popular for having a national network, since folks in these rural, remote communities are often having to travel for healthcare, and having a broader network of providers to access that are considered in network is really helpful. And the last thing that I wanted to share was they also shared that they were seeing several households that have chosen to go with faith-based health share ministry plans over the past, have decided to try the marketplace this year. And usually that's been because these plans would better meet their needs. And also, again, a lot of these folks are traveling out of the area and can access those more national networks through these plans. So that's kind of what we've noticed. And I would also definitely agree with all of the other points Miranda shared from the community partner grantees. Thank you.
Thank you, Miranda. Thank you, Holly. Did you have follow-up questions, Greg? Yeah.
No follow-up questions. Just appreciate the feedback from the marketplace committee members.
Thank you. I think we have one more, maybe, I know I'm stretching it, but this is just really robust conversation. I would hate to stop a momentum. Michael Wallace, do you have any additional feedback you want to share from other agents you've heard from?
Yeah, I mean, thank you, Chicky. Largely the same. Really open enrollment for this plan year went really well. Overall, very few technical issues. I mean, there were a couple here and there, but nothing on any kind of a broad range. And that's both with healthcare.gov and for folks using the web broker platforms like Health Sherpa. So 2 thumbs up for all of that. Everything went really well there. I think maybe just a couple out of our 29 partners, had indicated that maybe it was a little slower this OA, but really, by and large, folks thought it was busier. And so we'll see how the open enrollment numbers fare based on last year and have a good compare contrast that way. But no, just really happy with how it went. Really thankful for the partners and the agents that we have across the state doing the great work to serve Oregonians. And so, yeah, really just a big thank you.
Thank you, Michael, and thank you, everybody. To close out this agenda item, please know that in April, we would love to continue talking about this. So if you have an opportunity to gather more feedback from the community, we'd love to hear it again in April. Hopefully by April as well, we'll have more data from CMS that will support kind of what we're hearing from the ground. So I think April, I'm looking forward to April. I'm super enthused by all. I ran out of space in my paper. Luckily, we're recording this meeting, and I will take more notes after I review the recording. So thank you to all our committee members and to our staff who contributed. Please continue gathering that feedback, and I'm looking forward to more conversation in April about open enrollment debrief.
All right, we're going to move on to the next agenda item, and we're going to get a basic health plan program update from Tim Sweeney and Lindsay as well. I think Tim will start.
Yeah, good morning, everyone. Tim Sweeney with the Oregon Health Authority Office of Health Policy in the Health Policy and Analytics Division, and here for another update on the Bridge program, basic health program, and the work of the task force. And I didn't see Lindsay on the roll, but if I missed that, or if she's here, I think there's a couple spots where we can ask her to sort of weigh in with any reflections she has on the committee.
So Tim, can we interrupt you real quick? Yes, Lindsay is here and she's in the room.
Oh, in the room. No wonder I couldn't.
That's why. Yeah, you're good.
Great. So just, some of this is sort of the standard structure to this presentation agenda item is a little bit of a background refresher. I know not everyone sort of like lives and breathes Bridge program like I have been for the last 9 months. So I think it's always useful to highlight what it is again, and then we'll talk a little bit about the federal submissions planned and the timeline for the next couple of years. And so the next slide, I always leave these transitions in there when they're not needed. Sorry. So just a quick background, and I think that there's another redeterminations presentation later today, but the continuous Medicaid coverage provisions in the public health emergency has led to robust increases in health coverage in Oregon. And during the 2022 session in particular, as folks started to understand that the redeterminations restart was eventually looming, one of the data points that was highlighted during session was the fact that really the largest coverage gains noticed in the state were among adults with income between 138 and 200% of the federal poverty level. These are folks who were certainly eligible for marketplace coverage previously, and prior to the enhanced subsidies from ARPA would have had to pay monthly premiums and had copays. But so some of the coverage gains also maybe could have been seen because of the ARPA subsidies, but in particular, we think a lot of folks in this income range have stayed on Medicaid who would have otherwise gone over the income threshold and had to find commercial coverage. So the continuous coverage provisions we think had a really big impact on keeping folks in this income range covered. And so the legislature decided to appoint a task force really to develop a new program targeted at folks in this income range, really to maintain these coverage gains once the redeterminations, once the typical redeterminations process restarts in Medicaid. So the next slide highlights the charge to the task force in doing this. Really is to provide an affordable, coverage option for folks in this income range and improve continuity of coverage, keep people on their coverage through income fluctuations, and also to develop strategies to mitigate any potential for negative impact on the health insurance marketplace and the people who will continue to get health insurance through the marketplace. And so we'll talk a little bit about their conclusions on both of these fronts. So then the next slide, and I'll go through this kind of quickly because I know we've talked about this before, but this is the vision of the Bridge program, is that folks in this income range stay in their current CCOs. They're covered by the same plans that they are in Medicaid. And so when they move between Medicaid and this Bridge program, they don't see any change in their coverage. That the plan would have little or no cost for enrollees, including premiums and or copays. That it would cover a robust set of benefits, at least the essential health benefits, but ideally something closer to what is covered in Medicaid. That the payment rates to those CCOs, to the health plans, would enable them to pay healthcare providers at higher rates than they currently pay in Medicaid. And that ideally, people in this income range would be offered a choice between this basic health program and continuing to receive subsidized marketplace coverage as they do now. That is the vision as laid out by the bill, and then the task force was directed to take that vision and develop a plan in more detail. And so the next slide highlights what the final recommendations were from the task force, and it includes, just for reference, a brief summary of who was on the task force, how often they met. There really was an incredibly productive, 8 months or so of meetings, and it covered a wide range of topics, and I think which is evidenced by the broad set of recommendations. I think most of the recommendations are very consistent with the vision of the bill. For instance, really the first several of them, coverage or administered by CCOs. One detail is the first one. The bill did not direct the task force on the federal approval pathway. The task force, based on some feedback from CMS, included in their recommendations that we pursue a Section 1331 basic health program, which we'll talk a little bit more about. So that will be the federal mechanism to establish the Bridge program. But more broadly, it's a pretty consistent set of recommendations with the vision of the bill. To just highlight a couple of them, number 14 is that the task force recommended that the state consider continue to work towards an idea that would establish the lowest cost gold plan as the new benchmark, replacing the second lowest cost silver plan for the calculation of tax credits. And this is, I think, the one that is maybe most relevant to the marketplace and the work y'all do. This is the attempt to mitigate any negative impact that the creation of a BHP might have on marketplace consumers. That in theory, there's a chance that some marketplace consumers could see some increases in premiums, and this is an effort to offset any of those potential premium increases. I do want to pause here for a second, and I think this would be a great place if Lindsay, through your role on the task force, if you have any sort of additional reflections or thoughts on the process and the recommendations that you'd want to call out specifically.
Thanks, Tim. So yes, lots of meetings over a significant time period, but I think leading to what I recall as sort of unanimous support for the recommendations, which is important just to understand as a launching pad going forward, depending on what happens. I think a number of the recommendations are probably familiar to this group. I recall the most kind of, I don't know if debate is the right word, but most strongly held views and conversations about providers and community impacts when it comes to numbers 7, 8, 9, 12. I think that it seemed to me at least, and Tim certainly disagree if you see it differently, that there was pretty strong consensus around CCO service package and no enrollee costs. Lots of conversation about provider reimbursement. What does paying CCOs allow for providers? And then we've talked here about the gold benchmark, but that really being a really important conversation because the second subsidy proposal that came before this was really administratively unworkable for folks. So happy to answer any questions or reflect on some of the debate. I would also point out for this group that you gave feedback that we captured in number 13 around engagement and oversight. That I think will vary based on the timeline and some of the feedback from CMS. I assume Tim will cover, but that's I just wanted to call that out as well. Thanks, Tim.
Yeah, thank you, Lindsay. And I in particular that note about it being a unanimous vote for these recommendations. I do think that is quite an accomplishment for the task force, considering the diverse viewpoints that different task force members brought, and the breadth of the recommendations that were put forward. To have had that level of consensus, I think really puts OHA and DCBS in their role, especially with the gold benchmark strategy, in a really good position to go have these conversations with CMS, knowing that we have a unanimous task force vote that had such wide-ranging representation on it to help us make our case. Any questions on all of this before going into a little bit of detail on the 1331 and 1332 proposals? Yeah, I see a question.
Hi, Tim. Hi, Lindsay. Thank you so much. I have a question on the 789, and thank you for Lindsay to explain that. I hope that will make more providers coming into network, so the network would be bigger. But I have a question on number 10. So I thought that there is no cost for enrollee. So can you elaborate on that? Thank you.
Yeah, I mean, that is recommendation number 10, is that there will be no monthly premiums for Bridge Grant enrollees, and no copays, no deductibles, no co-insurance. That it really is a Medicaid-like benefit from a out-of-pocket cost standpoint for members.
Maybe just to clarify, like, this has no impact on folks who remain in Medicaid. This is for folks who might transition. So if you're thinking, well, that wouldn't be a change for them, that would be the point.
Yeah.
Oh, and I'm sorry to ask more. So when we heard earlier from Stephanie, that the House coming in with more conservative, and they're going to cut more on Medicare, Medicaid, and Social Security, this is not going to affect us in terms of state.
Yes, that's absolutely right. That's a great call out. So, and this is maybe a great transition, and if there's no more questions, I'll use that as a transition to get to the next slide, which really starts to look at like what this is. So what the Section 1331 blueprint is, and why Stephanie's update around the changing priorities of the U.S. House doesn't really put this effort in jeopardy. And so the Basic Health Program is a provision in the Affordable Care Act. It is already in federal law, and states basically have the option to create a program that would use the funding that would otherwise go towards tax credits and other financial assistance to people to purchase marketplace coverage. So essentially what this does is, for folks in the 138 to 200% of poverty range, who in absence of this program would go to the marketplace and get tax credits, Oregon is instead able to get the aggregate value of the tax credits that all of those folks would have gotten if they'd purchase marketplace coverage, and instead use those dollars to fund this Basic Health Program. And Oregon has a decent bit of flexibility in designing the program within some broad federal parameters. And largely the federal parameters are that, it has to be at least as generous of coverage as what folks would have gotten in the marketplace, and it can't cost enrollees any more than their coverage would have cost in the marketplace. And so we have done a really significant amount of actuarial and other analysis to make some estimates, and based on the cost estimates that we've gotten from our Medicaid side, believe that this funding pot would be adequate to enable us to deliver this benefit without charging monthly premiums, co-pays, co-insurance deductibles for those members. So that gets to the why we can do this without enrollee costs. And I know not all of that is on the screen, so I can stop for a second. And I do see there's a question before we go any further. Sorry, I missed who the question was, and so
Well, it was Gladys. I raised my
Yeah.
hand. So, because my first thought was and I think you answered it as you explained. So monies are not going to be taken away from those that already have. So if Gladys has $100 tax credit, I'm not going to get 75 because 25 needs to go to this pot. It's Billy over here would normally get $300, but because they're not enrolled, then that $300 would get lumped in with the 200 over here, the 400 over there, the 50 over here of those that are not enrolled. So it's not touching those that are already enrolled or that would enroll. It's not taken away from them, correct? I just want to clarify that.
So, and this will be a nuanced answer. Yes, it is not taking away from them in a sense of like the tax credits are explicitly reduced to pay for this. There are some sort of like secondary impacts on the market that we'll talk about in a second, that basically is when you remove a population from the market, things change. The pricing of the plans change, and sort of the formula that calculates the value of a tax credit could change for somebody. And it may or may not affect what they can buy. It kind of depends on their plan choice decisions. And we'll go through that a little bit, and then we can talk about the gold benchmark strategy and sort of how that is designed to address that reality.
Okay. And I'm hoping I'll continue listening as you continue, because the next question that, if you're going to answer, that's fine, is since this is a bridge plan, I'm assuming it's for a specific finite, and it's not an infinite, but it's a finite amount of time that they can be on this plan, correct?
Well, it is for as long as their income is in this range. It is a finite income range, which is 138 to 200% of the poverty level. So it's not that they're limited to being on the plan for only a certain amount of time. If their income is at 180% of poverty for 5 years, they could be on the plan for 5 years.
Okay. Thank you.
The assumption, and sometimes this is right and sometimes it's wrong, is that at this income range, there are definitely a lot of folks whose income fluctuates from one year to the next. And so if they're fluctuating above and below 138% of poverty, the fact that this mirrors Medicaid keeps them in the same plan consistently across years. If their income fluctuates above and below 200% of the poverty level, then somebody could be moving from this plan into marketplace coverage and back. And that gets to the aspect of the initial legislation that directs us to consider giving folks the option to stay in a marketplace plan, basically to help folks whose income fluctuates at that point. I mean, broadly speaking, there's always going to be a transition point from when Medicaid begins or Medicaid ends and the marketplace coverage begins. And so this BHP eases that transition point at a lower income level and creates one at a higher income level, which we think is broadly better to have transition points at higher income levels because folks may be in a better position to navigate them. But ideally, we'd like to be able to minimize both of those. But that second piece is down the road. Sorry for a little bit of a digression. And I'll go through the BHP part more quickly because I think the marketplace side is really what y'all are probably more interested in. But a bit of a background of this is what the BHP is. It is a component of the Affordable Care Act that will enable us to take advantage of federal funding to create this new program. So the next slide talks a little bit about like this process is we create a blueprint, which is really the application to CMS that defines our program. And unlike, a waiver, unlike a Medicaid waiver or a 1332 waiver, there is it's a much more straightforward process. If we comply with the rules that are set forward, it will be approved. There's a lot of boxes to check. Confirm that the state is able to do X, Y, and Z. And so if we can confirm we can do that, they will enable us to create this program. And so plan design choices are broadly shaped by the task force's recommendations. We're in a lot of ways using the Minnesota program as for some guidance as to how we comply with some of the federal rules. 2 states have basic health programs, Minnesota and New York. Minnesota also uses their Medicaid managed care plans to deliver their basic health program. So we're looking more closely at Minnesota as a model. New York runs theirs through their state marketplace. And then, there's a lot of operations and management administrative components. And again, we're looking to the structure of the Oregon Health Plan to inform how that works because we're trying to keep the coverage consistent with what folks get on OHP. And so the next slide shows the timeline really for the next few months. And our starting at the end of this, the current plan is to be able to submit a final blueprint to CMS in July, at which point they would have many months to give us final approval before we think about launching first phases of the BHP in 2024. So working backwards, right now we're in the blueprint drafting phase, and that will go to agency leadership later in the spring. And then in May, we will begin 2 sort of separate but concurrent community engagement work streams. One is just a broad public engagement public comment period that is a federally required. It has to last 30 days. And one is a more robust tribal engagement period where by state policy, this is a 60-day period where we work with the tribes to understand any concerns or address any challenges facing their members. In June, we'll integrate all this feedback and bring the finalized blueprint to the Oregon Health Policy Board in July for approval, which is required of House Bill 4035. So now I'll pivot, and sorry for all of this. I'll pivot to the 1332. The next slide talks a little bit more about this strategy to mitigate any potential negative impact on the market. So this was a big concern of the task force, and we worked with Oliver Wyman, an actuarial firm that has extensive commercial market experience, and they did a micro simulation analysis to really project what would happen to the marketplace if we removed this 138 to 200% population and put them in a basic health program. On the whole, they found that the impact is relatively modest. There's not significant numbers of folks who leave the marketplace. And a big reason for this is that the enhanced subsidies from ARPA and now the IRA make it so that even after removing folks from who won't be on the BHP, most people face net premiums that are still lower than they were 3 years ago. And so the general feeling is that this will lead to a relatively stable market from an enrollment standpoint. Premiums for unsubsidized consumers will decline, in particular because and because the removal of silver loading lowers silver premiums. But broadly speaking, they found that the population between 138 to 200% is slightly less healthy than the overall marketplace population as a whole. So there's a slight morbidity improvement for the risk pool that reduces premiums a little bit. And then for silver plans, more particularly, there's a more substantial reduction in the gross premiums for on marketplace silver plans because of the loss of silver loading. Now, what this means is that folks who buy silver plans largely see the same premiums because that's based on the federal affordability chart. But people who are using their subsidies to purchase gold or bronze plans may see, or in a lot of cases, see a slight decline in purchasing power because of the lower silver premiums. Basically, silver plans get less expensive relative to bronze and gold plans, but that affects the calculation of the subsidies. So there's some projection of folks moving between metal tier plans because of that. And broadly speaking, the impact on consumers varies by age and income much more than it does by rating region. And I know we did a slightly more robust presentation on the silver loading and the impact on the market, and so we can sort of follow up with some of that information and if folks have additional questions. But the next slide sort of highlights the projections from that Oliver Wyman analysis about the market generally. And we can see that on the very far right, or second column from the right, the difference in overall enrollment in the individual market is expected to be 900 people. So it's a relatively modest overall impact, but you can see in between that there's some movement into silver plans and out of bronze and gold subsidized plans. Again, because the silver plan gets relatively speaking, the silver plan gets more affordable compared to bronze and gold plans. So I'll pause for a second, but really this is sort of like why there is this effort to pursue this gold benchmark strategy, which the intent is to kind of prevent that loss of purchasing power as we get rid of silver loading. Any questions before this slide? Okay. So the task force considered multiple different strategies to mitigate this impact. The first one was really what if we were able to give a flat subsidy? If we think folks are gonna lose $25, what if we give everybody $25 more and everybody is the same? We talked with the carriers. The task force had us set up some meetings specifically with the marketplace carriers to talk about some of these issues and how we could implement some strategies. And it really became clear that it was a relatively high administrative burden on the carriers to do this. And so another idea that had gotten some discussion early and we kind of went back to based on the carrier conversation and frankly based on some direction from CMS is what if instead of the second lowest cost silver plan as the benchmark, we considered having the lowest cost gold plan as the benchmark. That in most cases, the value of the lowest cost gold is not terribly far away from the second lowest cost silver with the silver load. So it has potential to be an elegant solution. In conversations with the carriers, I think and I know some of the folks who are at those meetings are also here. So correct me if I'm misstating, but there was really substantial support from the carriers to keep pursuing this idea. It would be much easier for the state to implement. That said, there are still some federal challenges with this, and so the next slide sort of talks about what our next steps are in figuring this out. So again, we're continuing to work with Oliver Wyman, who did the previous analysis, to estimate what the cost would be to move from the current second lowest cost silver benchmark to the lowest cost gold. And there's really sort of like two hurdles we need to achieve. Is one is it needs to be deficit neutral at the federal level for CMS to enable us to do this. It needs to be operationally feasible at the federal level for them to do it with healthcare.gov. And then it needs to be financially feasible at the state level, that we're still the combination of Oregon's reinsurance program and this gold benchmark still leads to enough pass through for state leaders to be comfortable with the overall costs. And so we expect some initial actuarial results over the next few weeks, and then we'll be continuing to work with CMS to develop a much more sophisticated and substantial actuarial analysis that will inform a 1332 waiver amendment application that we would submit to CMS later this year. And the last slide really is just seeing all of this timeline at once. And so I didn't talk about phase one, and for the most part, I think I'll leave that alone for a minute and just focus on the other two timelines for a sec. But again, we expect to submit our BHP blueprint application to CMS in July with the hope that it is approved by the end of 2023 for potential phased implementation in 2024. At the same time, we'll be having the tribal and public engagement efforts with the BHP. We're also going to do that with the 1332 waiver concept, with the intent of submitting to CMS also in the summer. That will be a more substantial negotiation, I think, with CMS to get approval for the gold benchmark concept. But again, we hope to get that, late 2023, early 2024, which would give CMS and the state, all close to a whole year to really develop the processes and making sure that the healthcare.gov systems can accommodate this switch, with the intent of January 1, 2025, we would have a full basic health program for all adults between 138 to 200% of poverty, and that we would move to this gold benchmark to mitigate any potential for premium increases on the folks who still get coverage on the marketplace, folks above 200% of poverty. Briefly speaking, phase one, the blue bar there, is when we start the redeterminations process in a couple months for Medicaid. The goal is to keep folks who will eventually be covered by this BHP, to keep folks in their Medicaid CCOs while we do all of this work to stand the programs up. So we don't have to send somebody to the marketplace in September of 2023 or in order just to bring them back to a CCO based basic health program at some point in 2024 or 5. So with that, I'll stop, and I know we're a little bit over, so sorry about that, but I'm happy to answer more questions.
Hey, Tim, this is Craig. Are you available to stay around for the other items on the agenda?
I can, and I think especially if there's some guidance and thoughts about when and I can look at the agenda too to be around for certain ones. I wasn't planning on being here all the way until noon, but I certainly can be around for.
Well, the reason
for
I asked is
questions.
we're running a bit behind, so I
Yeah.
think I want to get to the public comment, but I think we have similar topics right after this.
Yeah.
And then maybe people can hold their questions and add those. Did you have anything that you wanted to add, Lindsay? Thank you for your comments. Appreciate that. All right, so why don't we open this up to public comment at this moment? All right, hearing none, I think we'll take a break, but we're going to shorten this break if people don't mind. I'd like to see if we can get it back about 10:36, technically 5-minute break. So why don't we do that? Thanks. Okay, welcome back, everybody. It looks like we're doing well to get back on schedule. So next on our agenda is the marketplace team, and they'll give us some marketplace transition proposed plans.
Hello,
Thank you, Craig.
everyone.
Great. Go ahead, Amy.
Okay, sorry, Chicky. Good morning, everyone. Amy Coben here. I'm the stakeholder and communications analyst for the marketplace. And I'm going to talk just a little bit about the consumer experience. And we talked about this at the last meeting. So this is a little bit of a refresher, but also updated with the federal omnibus bill that did pass. So just a reminder that this is kind of and I know it's small, so it's kind of hard to see, but this is a process map that shows a consumer's experience when they're determined no longer eligible for the Oregon Health Plan, and the different notices that they receive in terms of their closure notice and then where their information gets sent. So this is what the process looks like currently. And the reason we're showing this is to really highlight where the Marketplace Transition Project, which is formerly, we've been calling the Medicaid migration to the Marketplace, but we're now calling Marketplace Transition. And Dawn, if you can go to the next slide for me. So the Marketplace Transition Project fits in this little red box here. So once someone is determined no longer eligible for the Oregon Health Plan, their information, they'll receive a closure notice from the Oregon Health Plan, but then their information gets sent to both the federal marketplace and the state, to us at the Oregon Health Insurance Marketplace. And so that really allows both us and the federal marketplace to have touch points with the consumer to let them know about the marketplace as a potential health coverage option, since they are no longer going to be covered by OHP. Federal marketplace notices are pretty, they will be sending letters to remind folks that and I'll show you more about phasing later, but they will be sending notices to folks, but we will also be doing some outreach and trying to educate folks about their options a little bit more thoroughly. We plan to do this through letters, text messages, and also phone calls to folks who have been determined to be no longer eligible for OHP. And this will be in phases. So the calls will be to people who haven't responded after a certain period of time. We will have a call center that we are standing up that will help people specifically transition over to the marketplace and understand what their options are. And then, of course, connect them to local assistance. And then we're going to coordinate as closely as we possibly can with community partners and insurance agents and brokers to make sure that everyone has the information that they need to properly help these folks, and to make sure that we're connecting people with that expert help, because we understand that this is going to be a very confusing process and very frustrating for many people to have such significant changes, not just with their medical benefits. And so we really want to make sure that we have those touch points available. Next slide, Dawn. So this is our updated redeterminations timeline in light of the omnibus bill that passed at the end of December. That bill did uncouple the redeterminations process from the public health emergency. So we are no longer waiting on a 60-day notice. We did get more than 60 days notice, which is great, that we need to start the redeterminations by April 1st. Just a quick side note, and I'm not going to go into great detail because I honestly am not a subject matter expert and I don't want to give misinformation, but I do know that at the end of February or March 1st, the extra EA food benefits tied to SNAP program will be ending as well. So I just want to highlight that as another key provision. So the redetermination process will begin April 1st. When the notices are sent out, they will be sent out in batches monthly, and there is some phasing that has been, determined with the help of the community and partner work group to determine what those phases will look like. So they will be sent out. Folks will have 90 days to respond to the notices. Hopefully everyone responds, but we know that unfortunately some people will probably not. If they do not respond within the 90 days, they will then receive a 60-day closure notice from Oregon Health Plan. If they do respond and they're determined no longer eligible, they will also receive a 60-day closure notice. So that is great that people will have more notice and more of an opportunity to enroll, because we do know, of course, that the special enrollment period starts 60 days before benefits end. Next slide. So last month, when we met, I did show this graphic as well, but we did update it because we are officially in phase 2 of the communications approach. Phase 2 is really starting in February, and we anticipate it will go through April until that redeterminations period begins. In phase 2, what the Oregon Health Plan and OHA and ODHS is really focused on is making sure that people understand what to expect, when the process will start. We know that a lot of people are going to be wondering when they should expect to receive their notices, their renewal notices, things like that. So really trying to figure out how to communicate that is what we're doing right now. So that folks know what to expect, and that it's not overwhelming, as the process is naturally kind of going to be. And then reinforcing the importance and the urgency of making sure that we have correct contact information for all of the currently enrolled folks. So those are the two highlights. We are currently on the communication side of things working on revamping our partner toolkits, our talking points. Of course, the marketplace does have updated talking points, but the larger project is working on updating those talking points as well as getting other materials ready. So, and then once the renewals begin, we will start to move into phase 3, which is the renewal period. And that's really making sure that we're communicating with folks of how do you keep your benefits? What do you do if you lose you're no longer eligible, and things like that. Next slide, please. So I did put together this graphic, just basic graphic to kind of help illustrate what sorts of notices people will receive and what the timeline will be on those. Again, I do want to reemphasize, just to level set, that the marketplace special enrollment period is longer than 60 days in this instance, because it is for loss of coverage. So it begins 60 days before the date that the benefits will close, and then it ends 60 days after the date that the benefits close. So of course, we want to encourage folks and try and get the information out into people's hands before their benefits close, so that they can take action and avoid any sort of gap in coverage. But we will, of course, be helping folks through that end period as well. And then I do also just really quickly want to mention, that is not on this slide, but we do still have the 150% FPL SEP, or special enrollment period, that is still available. And then also tribal members as well, who can enroll, disenroll, or change plans at any time throughout the year. So we do have a couple of other opportunities for folks. We really want to make sure that we're messaging that clearly, so that people don't feel like they are going to miss that window. So again, OHP is going to send a 60-day closure notice. Basically, as soon as someone is determined no longer eligible to receive OHP benefits, that information will get sent to our team at the state marketplace, and we will be sending a notice to folks. We did send draft versions of those notices in the handout packet, so hopefully you guys saw those. In just a moment, I did want to ask for some feedback on that. So just as a warning that that's coming. But you'll notice in those notices that we are getting a little bit more granular intentionally. Typically, the way that I think is like, we want to keep things brief. We want to get people to our tools and resources. But in this instance, we want to make sure that it's tangible and that people really understand what savings are likely available to them. So there will be a little bit more information in there. So we will send out a letter to folks, letting them know kind of where they stand and what their options might be through the marketplace based on the information that has been sent to OHP under the renewal process. So it will be updated information, not information that's been stored in the system for some time. 30 days before the end of the special enrollment period, if someone has not actually enrolled through the marketplace and their information was sent over, to the federal marketplace, then they will receive a letter from healthcare.gov that just reminds them, don't miss out on your opportunity to enroll. It will be a little bit more higher level, so it's not going to get into the weeds as much, but they will receive that as well. And then just to also bring up that we will have other touch points included. We're going to be doing some text messaging outreach, as I mentioned before, some phone calls, and working with community partner organizations that are marketplace certified to make sure that folks are really getting the information that they need in case of your contact information wasn't up to date. So next slide. And so that just brings me to my final slide here before I hand it off to one of my team members. I really wanted some feedback from you all on the consumer experience pieces. I know this was a really quick, I was trying to help make up some time, but this is really quick. So if you have any feedback on the letters, or the experience as a whole, would love to hear that now. And of course, you're always welcome to follow up by email as well.
Looks like there is a question. Yeah.
Hi, Amy. It's so I want to clarify the transitional deadline. You said, the phase one beginning on April 1st, and it has 90 days, and then follow up with 60 days of closing from OHP. So let's say if someone's ignoring all the letters or texts and phone call, so doing from April, May, June, July, August, they still cover through OHP, right? And
yes.
Then after that, so okay, and then that coming to September, October, November, December, they may think, just almost the end of the year. Why bother to have insurance? That's what I want to making sure. On the feedback, yesterday I replied back to Michael Wallace on the COEM thing. I don't think those people are eligible to get marketplace though, because they don't have social security, they don't file tax, and they hate to say this, illegal residents. So that's my feedback. Thank you.
Thank you. We did actually receive a couple of folks, I think yourself included, had mentioned something about the COEM, and we know that for a large portion of folks who are enrolled in COEM benefits, that is true, that they may not qualify for marketplace coverage if they have no documentation or, for reasons that you mentioned. However, there are a good amount of people who are on COEM who, for example, may have a lawful permanent resident status and they've had that for less than 5 years, or they have some other marketplace eligible immigration status that does not make them eligible for Medicaid benefits. So we know that is a smaller population, but we want to make sure that we're getting tailored messaging out to those folks so that they understand that there's a possibility that they could have full benefits on top of their emergency only. But thank you so much for the feedback. I just wanted to make sure to clarify that before we continued.
Any other questions for Amy on her piece? I actually have a follow-up for you, and it's kind of tied to Elm's question. So I think she highlighted if someone received their notice on April 1st and they ignore it, they're covered technically for 5 months because they have the 90 days and then the 60 days. But aren't the notifications going to go out in batches through that period? In other words, not everybody on Medicaid gets their notification on April 1st. Can you maybe describe that a little bit?
Yeah, absolutely. And I apologize because I did not do that earlier, so that's my fault. So the way that the phasing is going to work is the community and partner work group and folks here at the state, we did really analyze who are the higher risk populations of not being reached. And so basically what they're doing is, just as a quick summary, and we can dive more into this later, but they're going to push people to the front that they think they're going to be able to get through the system more easily, and then save folks for the end of the process that are maybe harder to reach. So like maybe folks who are experiencing homelessness or, you know, some of those kind of populations. And so it is going to be in batches. It's not going to be all on April 1st. I feel like that would be just a complete nightmare, to be honest. But it is going to be in batches over the course of, I think they said 4 or 10 months. Misty or Chicky, someone jump in if I'm wrong. My brain's failing me right now, but it will be over the course of quite a few months. The period that I was discussing was just for like one individual. So if one person, when they receive their notice, they'll have essentially 5 months before their benefits end if they fail to respond or do anything. And so that would be the case even if you got your notice on, you know, month 10, you would still have that 5 months.
Great, thank you for that. And I think Tim was alluding to this as well, probably phasing the people who would qualify for the bridge plan later in the process.
Yeah, I have, you know, there's been some updated documents that are getting finalized on the phasing. So I'm more than happy to share, you know, more about that. You know, I can work with Chicky and Victor and you all to get that information out to you. I know that that's very something that a lot of people are probably interested in seeing. We are working on finalizing that, those communications. So, but yeah, I do believe that the bridge plan folks, they're trying to do it a little bit later to hold them on a little bit longer. Of course, that's tough because we don't know where people's incomes are right now. So we'll see how it works out.
Okay, thanks, Amy. Okay, I think we'll move on to the next portion here.
And that's me. Hi, everyone. I'm Katie Button. I'm the Plan Management and Policy Analyst for the Marketplace. And one of the things that I'll be helping us do is come up with some criteria to recommend plans to folks. So just to be clear, we cannot enroll consumers, but we can provide some plan recommendations to them. And if you read through the packet, the letters that Amy had included have some suggestions on or some places where we could put the plans. So we'll use our window shopping tool where we'll be able to input folks' information and then go in and actually select the plans that we want them to look at first. And so when they get the link to the tool, it will have those specific plans up, and then they also can go back by clicking up in the upper left-hand corner back to results, and they can see all the plans available to them, and it'll have all of their household information in there already. So hopefully that'll be a quick and easy way for them to look at plans. Next slide, please. So we have 4 marketplace carriers who are affiliated with CCO organizations, and it's been brought up, I think Jeremy Vandehay might have brought it up here. I know I've heard it in the task force. There's been some interest in thinking about, well, what if we just recommended that folks go to the carrier that's affiliated with their CCO? Could provide better continuity of care because the CCO and the carrier could share information. Maybe they have more network matching. And then also, if the CCO knows the person is leaving, then they could check with the commercial carrier to be sure that the person actually got enrolled. However, I think there are some issues with this idea. And so I'd like to talk through those, bring up some suggestions in alternatives, and then get your feedback on that. So next slide, please. So the first issue is availability. So we have 1/3 of our counties that don't have an affiliate. And then for folks who live in the Portland area, in the HealthShare, CCO, Care Oregon, and OHSU enrollees don't have an affiliate. So we would have to come up with a different criteria for those folks. Next slide, please. The next issue is premiums. As we all know, premiums vary widely across carriers and plans. We have lots of different options in different places. But in some counties, the plans that are offered by that CCO affiliated carrier are much more expensive. And these prices remain constant because of the way that tax credits are calculated. So for a 40-year-old, those price differences can range from $4.96 to $127 more than the second lowest cost silver plan for that CCO affiliated carrier. Next slide, please. And then our next issue is enrollment distribution. So, most counties have 1 CCO, but many counties have 5 carriers. Some counties have 6 carriers. And so if we recommend the CCO affiliated carrier, it might give that carrier an unfair advantage in enrollments. It might have the reverse effect and actually disadvantage that carrier because it is a lot of work to send out new enrollment packets, especially outside of open enrollment when carriers might not be staffed up. Regents and Bridgespan aren't affiliated with the CCO, so they would never be recommended. And then in work that I've done with some of the health share data, it's unclear if they would be able to tell us for folks who are enrolled in Providence and Kaiser, so it's possible that their plans would also never be recommended. Next slide, please. The last issue is choice influence, and we've had several situations over the years where we've either needed to select a new plan or a new carrier entirely for consumers. And when we do this, we see that consumers do actively go in and enroll. They don't just let the auto enrollment go through, but they often choose the plan that we have selected. And I think sometimes we do a good job at choosing the plan that's most beneficial for them, but I think often folks see, well, the state recommended it or the carrier or healthcare.gov, and they must know me and my situation and must be recommending the best plan for me. And I worry that they don't actually go and look at the other options. And so especially if the plan is much more expensive, I worry that if we recommend that CCO affiliated carrier that people will not go and look and see, oh, there are actually lots more options and some of them are much more affordable. Next slide, please. So now that I've laid out the issues, I'd like to propose a few solutions. So one thing we're looking into that's looking promising is being able to get consumers primary care physician information from Medicaid. And so then we can crosswalk that to our QHPs that cover those providers. And so when we know the consumers' providers, then we could choose the two lowest cost silver plans that cover those providers and say, here are two plans that cover your providers. If those aren't the least expensive plans in the consumer's area, we could also say, here in addition are the two least expensive silver plans. And then if we don't know a consumer's provider or they're not in network, then we could just send them information on the two least expensive silver plans. I feel pretty good about the two least expensive silver plans because in every service area, they cover primary care visits and generic drugs ahead of deductible. There's one plan in Yamhill County that doesn't cover specialty care visits ahead of deductible, but the rest of them all do. And then every carrier except Bridgespan is the second lowest cost silver plan in at least one county. So that means everybody would be recommended except Bridgespan. But Bridgespan is affiliated with Cambia, which is affiliated with Regents. So I'd love to get your thoughts and feedback. If you don't think of it today, but you think of it later, here's my email address. Feel free to email me, but otherwise, concerns, suggestions, all the things, let me have it, please.
Great. Do we have any feedback for Katie? Looks like Gladys has some.
Gladys, go ahead.
So one of the things that I did put it in the chat is that one of the other concerns, if you will, of sending them to the carrier, because usually the carrier, they'll stay in network with their provider, which is a great thing, but knowing the provider will help us because that provider could be contracted with multiple carriers, which you mentioned. But the biggest thing is that the carriers, if somebody goes directly to the carrier, they're not going to get the tax credit. So that's one of the concerns that I would have about sending anybody to the carrier, because the carrier is going to say, okay, well, Billy or Sally, whether they're calling Kaiser or Providence or Pacific Source or Moda, doesn't matter. They're going to give them, oh, well, here's the plan that we have, you know, whatever plan that is, and here's the cost. It's the market rate. They are not going to tell them, oh, and by the way, what's your income? They are not allowed. They don't have the ability to do that. So that would be the concern with going to the carrier. They truly need to go with somebody that's going to assist them find the best plan for them. That's going to help them actually enroll through Marketplace. So that they can get that tax credit and that lower out-of-pocket cost, and they're going to be guided properly. Does a bronze plan fit or does a silver tiered plan fit based on their needs? So that would be my only concern / recommendation that I would make.
So to clarify, we will be sending folks to healthcare.gov. We just would be sending them with a particular plan, but we also will be heavily recommending, as we always do, please go see an insurance agent who is free to use, who will tell you the best plan for you instead of us saying this plan might be a good fit. So thank you, Gladys.
Okay, no, thanks for that you're sending them to, because I'm like, when I heard sending them to carriers, I'm like, no, don't do that. Thank you.
Any other feedback on this approach? I think the question from what I gathered was a preference for if you're in a CCO that's affiliated with a health insurance company, that's maybe one approach that'd be familiar for that member, or go with the alternative of the second low silver with the added convenience of ensuring that the member has their primary care provider in network.
Yes.
So that's kind of the question on the table. Okay, thank you, Katie.
Thank you. So Michael and Miranda, you're up next.
Thank you. I had to find my unmute button there. My name is Miranda Amstutz, again, and I am the Community Partner Liaison, she, her pronouns. And I'm here today with Michael Wallace, who is our Agent and Small Business Liaison. And I'll hand it over to Michael for this slide here.
So starting off with the overview, so over 300,000 Oregonians are going to have their Medicaid eligibility redetermined, and more Oregonians will be informed if this health coverage options or their health coverage options and have access to affordable health coverage with the help of a trusted coverage expert. So that'll be our agents and community partners. Many Oregonians moving from a Medicaid to a Marketplace plan may not know how to utilize their plan or navigate their healthcare coverage. The Medicaid to Marketplace Migration Community Partner and Agent Grant Program will provide funding and support to partners providing outreach and enrollment assistance in Oregon. And grant funds will support an increase of Marketplace outreach and enrollment assistance for Oregon's communities that are at higher risk of being harmed by health inequities, experiencing disadvantage, and most affected by social inequities.
All right. The budget allocated under House Bill 4035 is $2.5 million, and of this $2 million, it's being allocated to community partners, and $500,000 is being allocated to insurance agents. We plan to make these funds available to all of our current partners to support the redetermination process during the public health emergency unwinding, and we plan to also utilize these funds to bring in additional new partners to address identified service gaps in communities most harmed by healthcare inequities and most affected by social inequities. So these new partnerships will help us increase our service equity by helping us expand our reach into identified communities of focus that we've identified service gaps by providing enrollment assistance, coverage. Sorry, the slides progressed. Thank you. Coverage option counseling and post-enrollment literacy support. We'll find organizations who are already working with and are trusted by the communities that we've identified that have service gaps in, and our outreach and education coordinators who are the boots on the ground and out in the field will help us connect to these organizations that we've identified to help us build these partnerships with to address these communities of focus. Next slide, please.
So current grantee support. Oh, sorry, go ahead, Miranda.
Oh, thank you, Michael. So this this chart here shows our current grantee support, and we have the most robust network of support from our grantees that we have ever had before. We just cover just the most communities of focus that we've ever been able to cover, as you can see here, in geographic areas around the states. Currently, so we have 14 community partner organizations that are our grantees, and we'll show you that in the next slide. But those partnerships those grants are set to end. Please go. So these are our grantees. Thank you. So those grant agreements are set to end July 31st of 2023. And as we're looking here at all of this robust coverage we have, I just kind of wanted to open it up to everyone here today to give some feedback. Do you see any communities that aren't listed here that we should focus on, especially during the redetermination process? Wanted to open this up to you for some feedback here and just pause for a second. Okay, thank you, Carissa. That is really great feedback. Carissa typed people with disabilities or people experiencing disabilities. Thank you. I'm going to take note of that. Do we have any other input here before we move on? Okay, thank you so much for that feedback. Next slide. And as we already showed, these are all of the fantastic organizations that are our community partner grantees. We're just, we feel so honored to be working with them and to have partnerships with them, and hope to continue to partner with them and build the relationships that we're building. Next slide, please. And then I'll hand it over to Michael again.
Thanks, Miranda. And so just as the slide before referenced our community partner grantees, this slide and the following slide gives you a good scope as to the number of partner agent grantees that we have, and also just have been a tremendous asset. And as with Miranda, we just really look to continue these relationships and have the great work for Oregonians out there.
This timeline here shows where we're at in the process. Like we talked about earlier with House Bill 4035, we're hoping with those funds to bring on a couple new grantees and to use those funds to extend our partnerships with our current grantees. You can see here that the unwinding process is going to start in April. That needs to be reflected here. It says the potential end of the public health emergency. That needs to get changed to the unwinding process will start. And that means that the workload for community partners handling the redeterminations, that's really going to be in full effect in May. So it would be really detrimental for partnerships to end in July, which is what is currently the situation. So we're just trying to put together a plan on how we're going to handle that, and then use these funds with our current grantees and to bring on some new grantees, hopefully to address to some communities of focus that we've identified. Next slide, please. So which brings us to how are we going to figure out what communities that we need to be focusing on. So we pulled some data. So first off, there's the public use microdata, which we call PUMAs, which is cross-referenced with current grantees. And we've identified the following gaps for community partners, and there's some additional areas that need some additional service that we've identified. Those gaps geographically, we've identified some gaps in are Benton County, Lynn County, and Yamhill County. Next slide, please. So we also took the prior year's data. This is self-attestation data from healthcare.gov. So this is information collected on the healthcare.gov application enrollment data. And we identified also the following needs. Some areas that we need additional support in is we need to focus more on our Asian communities in Oregon and the Russian, Slavic, Ukrainian communities in Oregon. And then also for agent support, specifically Latino, Latina, and Latinx communities, specifically in Jefferson County, and the Asian communities, specifically in Lane County. Next slide, please. And then we were also able to get information pulled from the ONE system And that just confirmed the information that I shared with you in the last slide, which was really good to be able to confirm that data with another source. Next slide, please. And then we also opened it up to get some feedback from our current grantees. We did a survey and we asked our grantees what other areas they feel need additional support. And then we also asked them for community feedback at our community partner check-in that we have monthly. And then they also confirmed the data that we pulled, which was there is a gap that we need to fill specifically with the Russian, Slavic, and Ukrainian communities. And also Marketplace grantees identified that we need to really bolster assistance for the Spanish-speaking community, which we have this year. We brought on several community partners that are specifically serving our Spanish-speaking communities in Oregon, and we extended that into Southern Oregon, which was a really big step for us. Next slide, please. All right. And then we already talked about our sources were, we also got feedback from the community partner work group, that survey I talked about, and then our community partner check-ins. And the next slide. Okay, now I'll hand it back over to Michael.
Thanks, Miranda. So for grant funding, current partners and new, the focus of this funding is going to be to allow our current grantees to add additional assisters or agents to support the redetermination workload that'll increase. And then current partner allocation of funds will be determined by partner interest, work plans submitted, equity and language support of communities most harmed by healthcare inequities and most affected by social inequities. And of course, the capacity of the partner to support the additional marketplace enrollments. Grant funding. Should we allocate, and this is going to be back to the group as far as getting your feedback. And what we're looking at is, should we allocate most of the funding to the current marketplace grantees and allocate some funding to new direct award grantees to support service gaps or additional service needs that we've identified? Or should we allocate all funding to current marketplace grantees with the ask to extend reach into communities that we've identified that there's an equity or service gap? So that's really the question that we're putting back to you all. And we'll pause for a moment or two here and see if anybody has thoughts or questions.
Does anyone want to offer? Okay, looks like we have as a.
Hello again. The concern, I think we need more help for sure, but the concern that I learned from my experience since receiving grant that we get more referral from the consumer side that they work with health agent who told them to just buy the cheapest plan. So if you want to allocate money to the new grantees, that's good, but there needs to be some, how can I say, some ethical that these people know how to do the job and not just sign people up, not asking the right questions, and help them choose the right plan. That's my comments. Thank you.
Thank you. Great feedback. And looks like we have another one coming in from Gladys. Gladys, I think you may be muted.
I am. Thank you very much. I was. So first, thank you, for that comment. My thought is it depends, and I think we need to kind of look at both things. Based on what you're requiring or what you're asking the current grantees, is it something that we can do? So that's number one. If we can do it, then by all means, we're going to do it. But if it's something that we're saying, I might not be able to do that, then bringing on others is a good thing. And then it depends, what is their specific, are they going to be doing something very, very specific, or are they doing what current grantees are doing? So it just depends on what the ask is. And I think if you go to the current grantees and say, are you able to do this? And these are the parameters and these are the requirements. If we say yes, then it's like, okay, then this is what we can allocate. Or if we say no, then it's like, all right, then those allocated funds will go to somebody else. And that's okay too. So I think it's kind of kind of a dance, if you will, and it's a depends from my end on what the ask is. So coming from somebody who has been very appreciative of the grants and being able to be, I feel that those of us that have received a grant to a certain extent, we are getting additional referrals because we're on the website, they're seeing us, consumers are, they're finding us. We all work together, we talk to each other, we send to each other if it's something we can't do. So we already have built a little community of our own, if you will. So we're okay with opening our arms to others. That's part of why we work so well together. But at the same time, we do want to make sure who are we bringing in and what are the expectations for them and for us.
That's great feedback. Thank you, Gladys. Appreciate that. And yes, there definitely will be, of course, keeping this brief, there definitely will be more information to come shortly with respect to the specific ask and kind of the parameters and what we're looking for as far as work plans and whatnot. So folks can look at and consider their bandwidth and make sure it works for them. And of course, then we'll look to fill in gaps on the back end. And so, but this is great feedback from both of you. Appreciate it. And we've got that noted down and we'll put that to good use.
Yes, thank you so much for your feedback.
Next slide. Were there any other questions I should ask?
Yeah. All right, I think that wraps it up, unless anyone has any more questions or feedback.
Thank you, Michael and Miranda. Really appreciate that. Why don't we move on to our next agenda item? We're going to continue with the theme, unwinding the continuous eligibility, and Vivian's going to talk to us about that.
Hi, everyone. Thank you for having me. I'm Vivian Levy. I use she, her pronouns, and I am the eligibility policy business director, which means that I am one of the people overseeing this unwinding process and hoping to make it as successful as possible. So let me talk a little bit about what we know and what we are planning. So as you all very well know, through the public health emergency, people have had continuous Medicaid coverage. Once you were found eligible for Medicaid or CHIP, you remained eligible, even if you had changes in circumstance. So now coming to the end of this continuous coverage protection, Oregon is going to, all states are going to be required to redetermine everyone who is receiving coverage. So in Oregon, that's a little over 1.4 million Oregonians who will have their eligibility redetermined over the next year or so. Next slide, please. So in December, there was an omnibus bill passed, and that was signed to basically set the terms for funding the budget for the next biennium. And as part of that, there was language that was included both to end the continuous coverage requirement, as well as to end the Supplemental Nutrition Assistance Program, SNAP, to end those emergency allotments. Both of these things were originally tied to the public health emergency itself, and they were not going to end until the public health emergency ended, but this omnibus bill decoupled those things and set end dates for them. Next slide, please. So what does this new law do? It does a number of different things. It requires states to end that continuous coverage requirement by April of 2023, meaning that by April of 2023, states need to start a redetermination process that could result in a closure or a reduction of benefits. There are additional reporting requirements that were imposed upon states, specifically around how many people moved in and out of the marketplace and some other detailed information about what was happening in states. So we're working to update our dashboards and our reporting with those new requirements. It also requires states to maintain updated contact information for beneficiaries. And so we have a number of steps in place to help ensure that we have the most updated contact information possible. There is a requirement for one-year continuous coverage for children. For all states, Oregon has actually had this in place for many years, and we're about to extend it as a result of the 1115 demonstration waiver that was approved. So we are already meeting this requirement. There was an extension last year of the postpartum coverage period from 2 months to 12 months. That was originally approved for 5 years, and this omnibus bill makes that approval permanent. And it also sunsets the SNAP emergency allotments with a February 2023 issuance. So what that means in a nutshell is that since the public health emergency started, many individuals and families have, well, all individuals and families have received the maximum SNAP allotment for their family size. And that could be the difference between what they would normally receive and that maximum amount can be as much as several $100s. And so for the last couple of years, everyone has been receiving that maximum, and that February of this year is going to be the last month in which that happens. And then people will go back to their sort of regular previous to PHE SNAP allotments, which may be much, much lower. So that's obviously an impact on people's food security that's occurring right around the same time that that people are potentially going to start losing Medicaid coverage. And so we want to partner really closely with ODHS and our SNAP partners to make sure that we are supporting our members who have one or both of these benefits as best we can. Next slide, please. So what does this mean? So it means that we have to initiate the redetermination process based on the different rules that we've put in place for this unwinding, giving people extra time to respond, giving people extra time before they are closed, which I will talk more about in a moment. We have never done this before. No one has ever done this before. And so we are doing our best to learn and adapt as we go through this process. We have built our renewal functionality in such a way that it is very flexible, so that if we learn lessons during the first few months of our redetermination process, we can apply those lessons to the coming months and continue to improve. So we're doing everything that we can to be open to new ideas and new ways of doing things that will help ensure that people stay covered or get transitioned to the right kind of coverage for them. And of course, that includes having strong communication and outreach plans, making sure that we have a workforce that is well trained and understands the new elements of eligibility that are coming back into play. For example, income verification processing, making sure that they have training on how to do that. And really just making sure that we are preparing both internally and externally, making sure our partners have the information that they need as much as possible. Next slide, please. So here is the redeterminations timeline. As I said, February is the last month in which the extra food benefits will be provided. So in March, those will end. Then in April, we will send the first batch of redeterminations, renewals, out to Oregonians, and that will those will go out to somewhere around 100,000 households in that first month. And we're going to have about 10 rounds, 10 cycles of redetermination. So people will be spread out over that 10-month period of time. And until they come up for redetermination, they will not be impacted by any changes in circumstance. So for example, if they have an increase in income in May, but they don't come up for renewal until September, they will not lose coverage until they go through that full renewal cycle in September. Next slide, please. All right, so we want to always keep our goal and kind of our North Star in mind in everything that we do in this unwinding planning. And so we have 3 primary goals that we're focused on. making sure that people who are still eligible remain eligible and retain their benefits without interruption. Making sure that people who aren't eligible for Oregon Health Plan anymore have clear direction and coordination so that they know what their options are. They know how to get a plan through the marketplace. They understand what they need to do to get into Medicare, whatever that next step looks like for them. And then making sure that we are keeping in mind the value of our community partners, our providers, our insurance agents, and making sure that you all have the messaging and the information that you need to be consistent and clear with people about what is happening, what's going to happen to them, and what their options are. Next slide, please. All right, I will not read every word on this, I promise. This is just to give you a general idea of the timeline and kind of the approach that we're taking. So right now we're in this before continuous eligibility ends, this green period. We are deep into planning, making sure that we have all the tasks that we need to accomplish, that we're tracking all of those and making sure that we're continuing the work of getting updated contact information wherever possible for our members, and really preparing for kind of the 60 days before the continuous coverage ends, which is that February and March timeframe, which is when we're going to be leaning in very heavily to getting communication out there, getting training out there. There's going to be some paid media out there to let people know what is happening, and really want to be as coordinated and communicative with our partners as possible, so that everybody has the information that they need. And then that renewal period will start in April. And that's where we're going to start putting our plan into play, and also learning about what works and what doesn't, and adjusting as we go throughout this time period. Next slide, please. And then last but not least, just so you sort of understand how this all fits in with the Bridge program. When somebody is found ineligible for Oregon Health Plan, once this redetermination process starts, if they fall into the criteria for the Bridge program, into that 139 to 200% FPL, they will move into the temporary Medicaid program. And this shows you the process, and I will let my colleague Tim or anybody else who wants to say more about that process. But this sort of shows you how we would move from that temporary Medicaid program into phasing people who are on OHP in that temporary Medicaid program into basic health plan. Into the basic health program in July of 2024, and then opening that basic health program up to anyone in Oregon who is eligible at the beginning of 2025. And with that, I am done talking and happy to take questions.
Thank you, Vivian. Looks like we had a question from Paul.
Hi, and it's about that temporary Medicaid program. Is that approved yet? Like, that's the piece I was unclear on between the Bridge plan talk and this one. So
that is a great question. So there is what we call an 1115 waiver request that is pending with CMS right now, that we are working with CMS on right now to create that program. And so we are in very close communication and coordination with them, and they're aware of when we need that approval in place in order to be able to start moving people in. But we do not have the official approval yet, because of the timeline in which all of this happened. Tim, do you have anything that you want to add?
No, I think that's right. Yeah, I think your answer is great, Vivian. Thanks.
And so then just to ask, I mean, are we confident? Like, are there contingency plans? I mean, I guess the volume just gets bigger, which isn't a good thing either. But so just curious on that too.
We've let CMS know that we really will be most comfortable if we can get to a full level of confidence and policy agreement with them by the end of February. We have already built this program. We have already implemented it in the system. It's just sitting there with the switch turned off. And so if the switch needed to stay off until we got approval, then we would very likely take some steps to try to make sure that, you know, we have already said that we've already done what we can to identify anyone who it looks like will move into this program and move them to the latter part of the redetermination process. But we would probably do some additional due diligence to do whatever we could to identify those folks and move those cases toward the end if that were the situation.
Okay, thank you.
Sure.
Thanks for the question, Paul. Any other questions for Vivian? I think I have one question before we let you go, and appreciate the presentation. So you mentioned 10 batches, which I think I've heard that number before, 10 months. Is that, can you explain that, why that's 10? Is it so we get through it by 12 months? I haven't quite got that.
Absolutely. So the CMS requirement is that we complete the entire redetermination process in 14 months. We know that we have a lot of risk around being able to do that because we know that we already have, ODHS already has an application backlog, and this is a lot of new work. And so we have done what we can to balance out the fact that we are giving people a lot more time to do things during this unwinding process with the fact that we need to have a finite end to when we finish all of the different actions. And where we've landed at this place, at this point in terms of that balance, is that we'll spread that initiation of renewals out over 10 months so that we can finish all of the actions associated with processing those in the remaining time that we have.
Great, that makes sense. All right.
Thank you all for having me.
Yeah, thank you very much. With that, we're going to move on to our next topic, and that is getting an update on legislative bills and session updates from our guest from the OHA.
Hi there. Can you all hear me? I'm having internet trouble today, and I'm happy to call in if okay. Thank you. My name is Philip Schmidt. I'm with the OHA Government Relations team. I actually come from Health Policy and Analytics, and I'm on rotation. So working with the folks at the marketplace is something I've been doing for the past year or so, and really appreciate you all having us here today. I wanted to just start by saying, the way the cookie crumbled was that your meeting is very early in the legislative session, this meeting today. They really got going in earnest on Tuesday of this week. And so the majority of the bills that they are introducing only hit the system last week. So OHA and all the other agencies, along with every lobbyist probably in Oregon, is flipping through all the bills to try to understand what they do, what the intent is, et cetera. So I think I have a few slides, Dawn, if you're able to pull them up. But we'll start with a slide that's a disclaimer, which is that this presentation is really for information only. OHA and the marketplace, our official position on any bill that the governor has not introduced via the agency is that we have no position. So we do not support, we do not oppose. We also are not neutral because we are not able to be moved to support or oppose. And then lastly, unless the governor herself changed our position and said, all my agencies are supporting this. And then lastly, OHA and I are not asking you of the committee to take a position on any of the bills. Again, just for information. Next slide, please. So key dates, as I said, legislative session just began a couple days ago. We, in order for a bill to move forward, it needs to be posted for a work session by March 17th. So that'll be a key date to keep track of. Bills that don't move through a first chamber by then are toast. Are not are posted by then. If they don't move through by April 4th, they're toast. As you see, then there's second chamber deadlines, and then they are targeting wrapping up by June 15th. They must wrap up by June 25th. So about 6 months of fun ahead of us. Next slide, please. So yeah, and next slide again. So bills of interest, we really are just in the very beginning stages of moving through our analysis of all the bills that dropped recently, and we actually do have a few coming in each day beyond that in the initial wave. We decided to pull out a few just to highlight for y'all, and I do think that I think DFR also has some bills that they're tracking and would be appropriate for this committee to hear about. I understand they may have come to your last session. Maybe they'll be coming to another one. But in terms of coverage, here's a sampling of those that have been introduced, requiring health insurance coverage of interpretation services. 2545 requires the health insurance reimburse the cost of behavioral health care services provided by a master's degree level students under clinical supervision. And SB 491 is around fertility services and treatments. And then we have several more beyond the ones on the screen, mandating coverage or asking OHA to study coverage of certain conditions and diseases. If we go to the next slide. The bill that the OHIM staff has flagged as being of particular interest is one around a dental assessment for plans. Chicky will correct me if I say this wrong, for plans offered outside the exchange. There's obviously an interest in continuing the work around universal healthcare, and we're tracking that closely to understand what the legislature is thinking. They've introduced a bill that would set up a committee to look at implementation of universal healthcare by, I want to say, 2027. There's a global budget pilot that would require a regional pilot where all payers and providers, what they envision, all payers and providers in region would be operating in a global budget environment. There will be a variety of workforce proposals. There already are. And also there's many bills regarding pharmacy and PBMs. So we could go to the next slide. I'm really racing through this because we really have fairly limited information at this point, as our analysts are really going through these bills to understand all the impacts. Obviously, y'all are probably aware of OLIS, but it's a great resource to follow these bills, to look at who's testifying or who has submitted testimony when the bills begin to move forward, to watch hearings, work sessions, and just to learn about sort of what's going on with the legislative body. And we in government relations, but also all throughout the agency are on this system practically by the every hour. And it's a fabulous resource to keep track of what's going on. I'm happy to answer questions if you have them. I probably won't be able to answer many about specific bills because we haven't run our analysis yet. But I'm happy to take any that occur to you about process or overall flavors of the legislative session, I guess is the best way to put it.
Phil, this is Chicky in the room. I know I've had a few community members who are interested in engaging or providing community input in legislative bills. So I know we don't have details yet on agency bills, but do you have any recommendations on how they can engage for other sponsored bills?
Yeah, and it's always a tricky thing because I think you kind of have to take your HIMAC hat off and put your whatever other hats you wear on. Of course, information that you receive through the HIMAC or from our staff can go into you submitting testimony, weighing in, meeting with legislators, taking part in the process as a private citizen or an interested party. We though can't sort of orchestrate advocacy by committee members per se. So Chicky and I can help you if there's things that you're and Chicky staff things that you're interested in, and we can provide information and for you to do with what you will. Does that help, Chicky?
It does. Thank you, Phil. I don't see any hands. Go ahead, Phil.
I should add, Chicky, that my colleague Mackenzie wasn't able to be here. I think that in future meetings we'd love to come back and provide updates as as we have more analysis and as bills begin to move forward and we identify priority bills for the agency that we're really tracking closely, to keep you all informed of that. We're just, again, so early that we weren't able to go that deep today.
Okay, thank you. Sure there are no other questions before we let Phil go? It doesn't look like it.
It doesn't look like it. So Phil, I know you're juggling attending hearings and doing analysis, so we appreciate you sparing a few minutes to provide us with updates. Thank you, Phil. Looking forward to future updates.
Thanks so much. I appreciate all your work, and we'll be in touch.
All right. Next, we're going to take a moment to see if there are any public comments. Not hearing any, we'll move on to our next topic, and Chicky's going to talk about departing members, member recruitment.
Yes, thank you, Craig. So as you all know, everyone's committee members' terms are every 2 years. And this coming February, the following committee members will be losing, or rather we'll be losing them, and their terms will be ending. So it's Lindsay Shirahama and Kathleen Jonathan. Kathleen is not here today. Lindsay, if I'm going to put you in the spot, I am so sorry. However, would love to offer you a minute or so if you have any thoughts you'd like to share with the committee. This is Lindsay did decline our request to consider extending or adding another term. So this is her official last meeting. So Lindsay, I know you're in there somewhere. If you would.
Hi, Chicky. Thanks for putting me on the spot. And I also appreciate you inviting me to stay on for another term. And I've really, really appreciated being a part of this committee. I've really enjoyed getting to know and hear feedback and hear all the experiences and everything that everyone has had to say being on this committee for the past 2 years. It's been really rewarding for me, especially when I was working with Project Access Now and in the program that I was in. Was super, super beneficial, and being able to share that information between my work life and the committee life and back and forth. And at this stage, I've stopped working there and have decided to do a life shift and go back to school, and which is the reason why I declined to stay on as a part of the Marketplace Advisory Committee. My plan is to go into physical therapy. So just big, huge shift away from program management with this. But yeah, so that's my reasoning. And, I'm excited I'm still very excited to see all the changes that are happening with the the migration and the bridge plan, and all of that is just like so amazing. And the work that everyone's doing, the work that we've been getting to participate in. It's really wonderful. And I'm so thankful to have been able to be on this committee for this amount of time.
Lindsay, we have been so lucky to have you. I know it was a lot to ask you for your time as you with your previous community partner organization. Your knowledge has been invaluable, and we are sure that you will be successful in your new physical therapy campaign adventure, if you will. Good luck with going back to school.
Thank you so much. Appreciate it.
Thank you, Lindsay. Best of luck to you.
So I think just so as part of the departing member agenda item, we still do not know what the new governor's executive appointments process will look like. So that is still being developed. As soon as we have that information, we will be heavily recruiting again. But in the meantime, if you have any suggestions, recommendations for other community advocates, other consumers, please do reach out to your friends and family. Would love to start talking to them already, even before we know the formal process, because as we all know, the formal process requires an application, a vetting process, a Senate confirmation, and it's probably looking like it's going to be the same. So would love to hear recommendations. Please do email me or text me. Would love to know if you have any friends or family that you know would love to be part of the Health Insurance Marketplace Advisory Committee, this fantastic committee that we try to make it as easy as possible to be part of. So that's the current ask. Again, Lindsay, thank you so much for your time. We look forward to hopefully seeing you in the future as a member. If hey, if you're just bored, come join us with any of our committee meetings. And with that,
thanks, Chicky, I'll do that.
Yeah, we're always looking for public comment, Lindsay, so you can fill in there. Okay, with that, I think we've reached the close. Did you have something you wanted to add?
I do. So it is January. And as we all know, legislative season just started. So wanted to segue into kind of upcoming work for the committee. So just as a heads up, we are still in the process of finalizing our timeline for our marketplace assessment rates for 2024. That is something that the committee is very heavily involved in terms of analyzing the modeling as we propose rates for 2024. That's something that we ask your feedback on. So that timeline is still being developed. As we move over from DCBS to OHA, the processes are different. So trying to build that in with the rulemaking and all the timelines we need to be mindful of. So just please know that's coming. Our next meeting is in April. I know that much. I can't remember the exact date. I know it's going to be a Thursday. Thank you. It's going to be on April 20th. And per our work plan, we will be talking about, open enrollment by the numbers. We'll continue our debrief. We'll get a legislative session update. So hopefully by then we'll definitely know which ones are our agency bills and bills of priority, especially our budget bill. It is an odd season year, so our agency will be submitting our budget requests, and that will be part of our priority bills. It looks like we will also be looking at the basic health program updates again. I think that's going to be kind of a standard standing item for the next year or so. And then also please know that the Marketplace annual report is coming your way at some point to review. We combined a committee update section in the Marketplace annual report, and this annual report is due to the legislature on April 15th. So all that to say, I promise you will not be bored with the Health Insurance Marketplace Advisory Committee for the next couple of months. It's going to be busy, but we do try to make it as hopefully as painless as possible to provide your feedback and get as many of your questions answered by the team. Team does a great job. Thank you, Lindsay. And that I think that's plenty. That's plenty for us.
Yeah, I think April will be an exciting month, particularly since we'll be already into the notification process too. So that'll be good to have that that timing as well. So as we wrap things up, I just wanted to thank everybody on the committee for your feedback. I think this was a very good meeting in that respect, and I think your feedback's particularly helpful these days with where we're headed with the redetermination process. I think there's going to be a lot of questions out there and confusion, so do appreciate your input as we go through that process, and that'll be, as Chicky said, on the agenda going forward. I also want to say thank you to all of our invited guests today for your presentations. Both of those of you that are on the Marketplace staff, you do an excellent job supporting the committee as well as from the OHA. So thank you for your time and presenting today. And with that, I think we can close the meeting. So thanks, everyone.
Bye all. Have a good rest of your week.
Bye.